Hi, welcome everybody on the replay session of the webinar Introduction to Passive Rehabilitation with FroggyMouth. If you are here, it's because you missed the live, so we made a custom replay only for you guys. It will be split into three parts. Functional rehabilitation, for whom, what it is. Second part, FroggyMouth, rules of use, how to use the device, how to explain to the parents and the patients how is the device working. Third part, the step-by-step protocol to be able tomorrow or the next month to start to use FroggyMouth in your daily practice. And the question and answer session that unfortunately you missed because you couldn't attend the live. I invite you to participate in our further webinars to be able to make the question and answer session, ask all your questions to the speakers, and if you are having still some questions unanswered, feel free to contact the FroggyMouth team. They will make sure that you have an answer for all your questions. So, we may directly start, and before starting, I have to say something. I am in front of you as Guillaume Fellus, the son of Dr. Patrick Fellus, because I am not a doctor. What I'm going to present you today is the work of my father, is the lifelong work of my father. I have to say that we are working together since a very long time, because you can see he was using a picture of me sucking my thumb back then when I was still sucking my thumb. As you can see in the picture, a little bit too late. I will advise myself to stop earlier if I could. And he was using this picture of me under cover of a very great book that was published in 2002. So we are directly going to start with the first part, the functional rehabilitation. It's very important, before speaking about the passive rehabilitation, to explain what is rehabilitation? What are we fixing? We all know these patients that is breathing through the mouth, that is having bad sleep quality, little black marks under the eyes, and also an open bite, as many of our patients. That leads us to the question, who is having dysfunctions? We know that FroggyMouth treats dysfunctions. What are the statistics about dysfunctions? Literature in the 60s were publishing those numbers. 40% of young patients and 30% of adults are having atypical swallowing, wrong tongue posture. It can seem a lot for some people, few for the people, but what actually matters is not in the 60s, it's nowadays. And it's not in the general population, it's on our patients. So a recent study published in L'Orthodontie Française, the biggest French orthodontic newspaper, by the wonderful Philippe Amat, is giving us a little bit an answer to this question. How many orthodontic patients suffer from myofunctional disorders? And the answer is surprising. It is 85% of orthodontic patients that suffer from dysfunctions. Now that we said that, and that we also know that, at least in France, but it is more and more the case in so many countries all over the world, it is mandatory for absolutely every orthodontist to make sure that at the end of the treatment, there is a functional balance to make sure that the results will remain stable. Great. Now that we said that, all the statistics, all the things I'm going to explain you today are available in sources, but also on PubMed, where you can find, for example, right here, the example of the article of Philippe Amat, where you can at least, I think, read the abstract in English. It's still something that is pretty surprising, because when we are thinking 85% of orthodontic patients, it's a lot. It's a lot for a species, us, the humans, that we are not at all having any problem for centuries. When we are looking at old skulls, everybody knows, and we are all asking ourselves the question, why all the teeth are perfectly aligned, including wisdom teeth that we are now removing. All those questions are leading us, not only that, but also to this painting. This painting has been made by George Catley, a very interesting character. He was born in the United States at the beginning of the 19th century, was having a great career as a lawyer, and then one day he decided he didn't want the life in an office and decided to become a painter. And to become a painter, he decided to move in and live for a couple of months, years, with the Indian Americans, the people living there since almost always. And he was noticing several stuff. One of the stuff that the American Indians were doing was keeping the skulls of dead people in the village. This picture that I am showing you right here is actually from the book of George Catley. He was writing this wonderful book called Shut Your Mouth and Save Your Life. Because when he was in the village and seeing all those skulls, he was noticing two stuff. First of all, there was almost no skulls of young children. Almost none. And the second surprising fact were that all those skulls were having no facial deformation, while actually having teeth not perfectly aligned, having deformation of the face, no matter what it is, isn't something that uncommon for his society, from his civilization. Even child mortality wasn't something that's uncommon for his society. And he realized that for all those Indians, it was not at all something that they were used to. Everybody was having perfect teeth, no face deformation, and a very low child mortality. He started to look for answers because it was surprising him. And then he realized what led him to his book, that there was something that all the Indians were sharing. They were always sleeping with mouth closed. They were always breathing through the nose. He was diagnosing at the middle of 19th century, publishing this book in 1869. He was understanding what is myofunctional disorder, not yet what is myofunctional therapy, but how to diagnose myofunctional disorders and what are the consequences that keeping myofunctional unbalance may have. It was so interesting for me to read this book that is older from more than 150 years old, where we could see all the stuff that we are still using nowadays in the myofunctional field in general, where so many people are saying that it is an emerging field, that it is almost something trendy that we cannot be sure about because it's a pretty new knowledge. No, actually what needs to be said about myofunctional therapy in general is that it is something part of the world and human knowledge since always. Breathing through the nose, chewing, having right tongue posture, right posture of the body, all of that leads also us to have no deformation and good teeth alignments. That is part of the eternal human wisdom. That's what George Catlin was identifying. And that's, by the way, almost the same way to assess myofunctional disorders that we are using now 150 years later. Because he was showing us all the facial contraction that people with dysfunctions could have. That's exactly what we are doing nowadays. Of course, we're also studying, for example, the angle that is right here to be able to assess the tongue posture without seeing the tongue. We are assessing the shape of the nasal orifices, but mostly we are looking at the potential contractions that we can have on the face. For example, this patient, we see directly he's perfectly swallowing. How are we seeing that? Right here, we are seeing that there is absolutely no contraction of the face, no contraction of the facial muscle. But right here, right now, you are seeing that there is contraction. When we are seeing this, exactly that you can see right here, those facial contractions, those lips that absolutely need to create a seal to be able to swallow thanks to a gap of pressure. All of those signs are clearly showing us that there is a dysfunction. If we are not sure of our diagnosis, we can also use another little exercise that I recommend for the mothers to show them how powerful can be dysfunctions. Use your little finger like that, as he was showing. Do not pull it too hard, just pull it like that to make possible with the finger to feel the cheek contraction. You see right there, this patient is swallowing perfectly, there is no problem. Right now, he's now swallowing in a bad way. You are directly seeing the contraction and you feel that the contraction of the cheeks bring his little finger close to the teeth and press it on the teeth. Now that we are all agreeing about the importance of treating myofunctional disorders and how to diagnose those myofunctional disorders, let's come on the FroggyMouth. Because FroggyMouth is exactly and only treating what I was just showing you. Wrong tongue posture at rest, wrong swallowing pattern, wrong breathing pattern, so mouth breathing. Those are the three and only those three indications to use FroggyMouth. All the other stuff that you can hear in some of our lectures, but also everywhere, are consequences of the myofunctional balance. For example, when we are speaking that it improves the posture of the body, when we are saying that it might be closing an open bite, for example, all of that are consequences of the myofunctional balance. What we need to really understand about myofunctional therapy is that we have a goal. This goal is very simple. This goal is the automation. And outside of that, all the rest are following potential consequences of us doing greatly our job of automating a great myofunctional balance. I'd like to show you this quote to emphasize the importance of automation. Marie-Yvonne Fournier was someone very important for the French myofunctional therapist, because she was one of the first one that was hard working on this subject. And she was having a very interesting thinking about myofunctional therapy in general. She was saying that too many people are pretending that myofunctional therapy relapse and that are saying that it is not working because of that. And so she was questioning herself, is it really a relapse? What those people are observing, and that might be true sometimes. No, because a relapse will mean that at some point we were actually healing the patients. If we were only having a neuromuscular answer to a given instruction, we are not actually healing the patients. To actually heal the patients, we need to automate the myofunctional balance. So if we are stopping the treatment before reaching this point, of course all the bad habits will come back. That's why we must have as target, as only target, the automation. And do not accept only a patient that is swallowing perfectly in front of us, that is breathing perfectly in front of us. We need to make sure that these patients will keep doing all those good functions, not when he is in front of us, but when he is going out, that he is hanging out with friends, or just being at home with his parents. Now that we are clear about the goal, we understand that we have to get more knowledge about how is the brain working and how an automation is created to be able to reach our goal. What we want to do is not only teaching something, is changing a habit. And all the myofunctional therapy that we are putting into action needs to take that into account. If we are coming back a little bit earlier on our life to understand what is atypical swallowing, what is wrong tongue posture, we are going back to the moments where we were babies, where we were just going out of our mother, taking our first breath of fresh air, at this moment we are not having any teeth. And until 3 years old, we will not have our dentition that will be complete. We need to swallow in a different way that is called the primary swallowing. This is the swallowing that we are using when we are going out of our mother from our birthday to be able to breathe, swallow saliva, eat. This requires a seal at the level of the lips because we are swallowing thanks to this movement going forward and backward of the tongue that is changing the pressure in the mouth and that is making us able to swallow thanks to a gap of pressure. That's what we are calling primary swallowing. And primary swallowing, as you can see right here on the video, require a seal at the level of the lips to isolate the mouth cavity from the outside. When we are growing old, we are reaching secondary swallowing. We are having a kind of swallowing that takes into account that we are now having teeth and that tongue cannot do anymore how it used to be, how it used to act, taking all the place and acting if there was no neighbor. Now the tongue is having roommates and it is the teeth. They need to be taken into account. So we are, after the age of 3-4 years old, after putting the chewing into action, swallowing thanks to secondary swallowing that characterized by the occlusion of the teeth and what we are calling the peristaltic movement of the tongue that you can observe right here, that is actually a wave movement of the tongue, raising the back part of it to be able to throw the saliva in the throat. It's exactly what you can see, for example, on YouTube, if you are typing this MRI, magnetic resonance image of someone swallowing a pineapple juice. You might see that there is more and more, of course, pineapple juice, which it's way bigger than saliva, and that's and that when he wants to swallow, he's making this peristaltic movement of the tongue, always keeping the back part of the tongue totally high. Why is this change from primary swallowing to secondary swallowing not happening naturally? That's the case for so many humans in the modern world. Why? Because so many of our habits have changed. We are keeping sucking habits way longer than before. That's why at 5 years old I was still fucking my tongue. We are also breathing an air that has more pollution than before. And last but not least, probably the most important reason, we are eating food that requires way less chewing than before. And that's why, at the age of more or less 3 years old, when we are supposed to transition from primary to secondary swallowing, almost half of the population is not doing it, and we are having half of our population that is dysfunctional, that is not having the sleep quality it needs, that is, for example, having tongue thrust, creating open bites or other kind of dental deformation. And that's why orthodontists have so many patients all over the world, in all countries, in all cultures, because many humans are having teeth deformation and all the potential bad consequences that can lead or that can be caused by that. That's exactly the reason why my father decided to create the FroggyMouth, because he was having the need to stabilize his treatments. As we were saying earlier in the introduction, we cannot have stable results in any orthodontic treatments if we were not fixing the myofunctional imbalance. And since he was treating young patients, he needed to find something to make sure that his young patients will go out of his office with an automated balance, so he could ensure to the parents long-lasting results. That's FroggyMouth, and I have to tell you a little bit how FroggyMouth has been discovered, because it is showing so well all the idea of the FroggyMouth. You know those lip, I don't have the name, those lip splitter are not only used on YouTube channel to make some contest or trends on social networks. They are used since always by doctors because every time that they need to work in the mouth, we need to remove the lips. And he was having, my father, one patient exactly as you are thinking. This patient was mouth breather having an open bite, exactly like that. So every time that he was swallowing his saliva, he was pushing the tongue like that. And one day, when my father was working in the mouth of these patients with the lips open like that, he realized that when he needed to swallow his saliva, he was putting the teeth in occlusion and perfectly swallowing. These patients that he was trying to treat with the help of the speech therapist of the hospital since several months with absolutely no results. Every time he was asking this patient to swallow in secondary swallowing, it was not working. To breathe through the nose, he was never keeping that. But right now, when he was just having no contact between the lips, every time he needed it, he was putting the teeth in occlusion and putting his tongue backward. Why and how? He was not knowing at this moment, but he was noticing something. When he was asking to these patients, why was he acting perfectly when no one is asking him to do so? The patient said something wonderful. I don't know. I am not doing anything differently than usual. And at this moment, he realized that there is something. That if we are trying to avoid the contact between the lips, to inhibit the lip seal instead of only trying to teach the patient what to do, we could make the patient discovering by himself the right way to swallow his saliva. That was totally making sense because in the 80s he was developing this little exercise that was used, by the way, by the speech therapist of the Robert Debré Hospital in Paris, where it was just a diagnosed exercise but very efficient. Pulling the lower lips like that and asking the patient to swallow. A good swallow, no problem. But all the patients that were having atypical swallowing, directly, they needed to get lips in contact and the lips was going out of the fingers. That's how he was able to diagnose in a very efficient way the atypical swallowing in the 80s at the hospital, and he was also giving this as an active exercise with the help of the speech therapist to so many of his patients. So that was totally making sense to actually create that, but a device that could work in a passive way. Because once again, the goal is the automation. So if this is very efficient to make sure that there is no contact between the two lips, it is also absolutely clear that the patient is aware of what's happening at this moment. But as you can see with the shape of the FroggyMouth is very simple, very physiological. You are forgetting that you are wearing it after a few minutes wearing it in front of the TV. That's why FroggyMouth keeps this idea, but works on a passive way. Froggy is making impossible the contact between two lips. As you could see once again, we need this contact to be able to swallow thanks to the movement of the tongue. When you wear FroggyMouth, you try to close the lips to be able to create the seal to swallow like you always did. Exactly what's happening right there, and it's not working. And the point is to make you discover that the only way if you want to swallow your saliva is exactly this. Putting the teeth in occlusion and making these peristaltic movements of the tongue to throw the saliva back. That's how is FroggyMouth working. And what's wonderful when you are doing that in your physiological way is that you are not only impacting swallowing, when you are changing on the long-term basis the posture of the tongue during swallowing, you're also changing the tongue posture at rest. And if you are able to implement a high tongue posture at rest, you are creating the physiological posterior joint to inhibit the mouth breathing. Because if there is something that we are all agreeing about, is the importance of the breathing. We never want to fix the swallowing if we are keeping a mouth breathing because the swallowing will not be lasting. Exactly in the same way that if you want your rehabilitation on the breathing to last, you have to change the tongue posture. That's why we're speaking about a functional matrix, because all of that influence each other. So, when you wear the FroggyMouth, you change the posture of swallowing of the tongue during swallowing, which changes the posture of the tongue at rest. And when you have a high resting posture at the posterior level, I ask you in front of your screen right now to try to raise the back part of the tongue, not the tip of the tongue, the back part of the tongue. Raise it like that. You are directly seeing and feeling that you are breathing through the nose on the most natural way possible. That's how and why FroggyMouth balance all the functions of the face. So now that we did that, it was only the theory. It's important to understand how to wear it. 15 minutes per day in front of television. Television is very, very important because it is keeping the look horizontal. The choice of the size isn't that complicated. If you are having a patient that is less than 10 years old for boys, less than 13 years old for women, it is usually a small one. If we are coming back to that, you can see right there the three sizes. Small device, 3.6 centimeters of width. And the medium one that is coming on the red box, 4.3 centimeters. And the purple one, the bigger one, that is 5 centimeters of width. That is really for the patients that are having a big mouth. If I am giving you all the measurements of each sizes, it's because it is not a question of age. It is really a question of the size of the mouth. You should look at the distance between the two corners of the lips, and we have to take something that is a little bit smaller to leave a couple of 3 millimeters on each side to make sure that the FroggyMouth will not touch the corner of the lips, something that we really do not want. If you are having any doubt, always pick the smallest one that you are thinking of. There is absolutely no FroggyMouth that are too small, but there are FroggyMouth that are too big. So if you hesitate, just take the smallest one, you will have absolutely no problem. As I was showing you, the large one is so only for a very small part of the population, the top 10 adults that are having the biggest distance between the two corners of the lips. For example, me, I'm a grown man, I'm 1.90 centimeters of high, and if I had to choose a FroggyMouth, I will definitely pick the medium one because the large one will be way too big for me. If you are still having any doubt about that, just go on our website to look at all the advices about the right choice of the size. Now, we can directly give that to the patients. Very easy. You give it, you just make sure that the V here is on the upper side, that we are not wearing the device on the wrong side, and that the patient is not putting their teeth inside. Then you ask your patient to wear it 15 minutes per day in front of television. Television, as I told you, is important to catch the attention and to maintain the look horizontal. If it's not the case, raise the level of the computer, as we were saying, with some books, so we can make sure to always keep the right angle at this level. It has to be worn 15 minutes per day, every day, and if, like this little girl, you are removing the FroggyMouth during the 15 minutes of wearing time, you have to restart from the beginning. It's very important that those 15 minutes are always wearing the FroggyMouth, always watching the TV, just in a good, cozy mood with your parents or alone, depending on what is the best for the patient. So all of that is a wonderful theory, but we have to make sure that this theory is working. That's why there is a lot of scientific studies that has been made years after years about the FroggyMouth. You can find them, by the way, on PubMed, on the FroggyMouth page on PubMed, or directly on our website. The first study that has ever been made was this one, 2017, made by the Dr. Pauline Cornu at the University of Lille. And what was, in my opinion, very interesting about this is, first of all, she was deciding to really only assess the FroggyMouth, not doing anything additionally than the FroggyMouth treatment. No, taking the FroggyMouth, putting it in the mouth of the patient, and assessing how is the patient after 5 weeks and how is the patient after 10 weeks. The wonderful results that she was having are even better because she made the difference when she was assessing the results between the engram only and the automation. And if we can see that after 5 weeks we are still having more than half of the patients that we are not discovering by themselves secondary swallowing, we can observe that after 10 weeks of treatment, 80% of the patients discovered by themselves without anyone explaining them the secondary swallowing. And out of those 80%, 3/4 of them automated the right swallowing, the right tongue posture, without even realizing that they were having a rehabilitation that was going on. A new recently published study was assessing the FroggyMouth in almost the same conditions, also making the difference between engram and automation, but was taking a larger group of 83 patients, if I'm not mistaken, while the previous study was only on 40 patients. And those 83 patients were split into 3 different groups. What is absolutely wonderful about that is that we are seeing almost the same results with every groups, and almost the same results than with the French study at the University of Lille. Basically, when you are only doing the passive therapy with FroggyMouth, taking the device, putting it in the mouth of the patient, that's more or less what can we expect. But what is very important is how can we go further than that. That's why I really loved the thesis of Dr. Fadani from the University of L'Aquila that was directed by Professor Gendini, and there is an article that has been really recently released, I think last week, about this wonderful study that was not focusing on the functions by itself, but what are the impacts of bringing back the myofunctional balance on the anatomy of the face. And so she was assessing if we can make expansion only by changing the tongue posture, because she was only considering that with FroggyMouth we are efficient at changing the tongue posture. And I let you directly discover right here all the results that Dr. Fadani was having, because she was proving at a statistically significant level that we are able to make expansion only by changing the tongue posture by using the FroggyMouth. As I was saying in introduction, it is not telling us that FroggyMouth always do that, but that FroggyMouth may do that. Last but not least, I really love this study of Dr. Quincy, also in Italy, that is once again available in PubMed, because additionally than assessing the atypical swallowing rehabilitation, as you can see over there, where there is 80% of success in the swallowing rehabilitation, he was also assessing how the FroggyMouth was improving the lip strength, which was not at all something that we were assessing on our own in France, but he did that, and he was proving the improvement of the lip strength, for example, by using FroggyMouth, which was pretty surprising for a device that is trying to inhibit the contraction of the lips. But when you are bringing back a functional balance at every level, you are making absolutely everything working in a better way. And once again, all of that is what other people are doing and are able to do with the FroggyMouth. We are arriving to one of the most important parts. What are you able to do with the FroggyMouth when you are or will be implementing the FroggyMouth in your office? It is very simple. First appointments, you make a clear assessment Is my patient needing a froggy mouth? Yes or no? Is my patient having a functional balance? Or is he or she needing a myofunctional therapy to bring back this myofunctional balance? If yes, we are asking ourselves the question, is this myofunctional therapy possible? At the psychological level, but also at the anatomical level, which is something very important. If you want a therapy to be efficient, you need to make sure that all the stuff that you expect your patient to do are possible. You expect your patient to move the back part of the tongue, make sure that the back part of the tongue can raise to the palate. Is the palate large enough to welcome the tongue? Is the tongue tie long enough to be able to make these movements? Even though we have to be very careful with the tongue tie to do not be in the too much, not be in the too less, if I may say. And also make sure that the occlusion that we are watching since the beginning is making possible for the patient to stabilize the mandibula by the occlusion. For example, if it is like that you are having a super big open bite, maybe that you first need to make the anatomical environment a little bit more compatible with the rehabilitation that you are about to start. But all of that is really for the top 10% of the worst cases. In most scenarios, you can just take the froggy mouth, put it in the mouth of the patient, make sure that the patient is not biting on it, is not putting the lips or the teeth inside, and look at this patient. Is it changing his way of swallowing or not? As you may see, for example, this patient, right now, he is still having all the face contraction when he's swallowing with the froggy mouth. So we are not in the situation of a patient that was having a direct engram, which is fully normal. That's exactly what we need to do on the first appointment. Taking the device, putting it in the mouth of the patient, asking the patient to swallow. Is the patient discovering spontaneously the secondary swallowing? That's wonderful. We may skip step 2 and directly go to step 3. Most of the time, it will not be the case. Give a little hint to the patient. Ask this patient to put the teeth in occlusion, to make a little step with him or with her. Most of the time, it will not be a spontaneous discovery on the first day, but this is something that is going to be very useful for the following weeks. And then you are just asking the patient to go back at his place, wear the device every day, 15 minutes per day. Now we are on the way to the engram. Before working on the automation that we were speaking about earlier, we first need to make sure that the patient's gonna discover on his own what is secondary swallowing. That is a very important point. All the stuff that we are doing right now is to help the patient to discover on his own the secondary swallowing. Why? Very simple. Everything that you are discovering on your own is easier for you to keep on the long-term memory than anything that has been taught to you. Everybody that was going at school can remember that so many interesting stuff were taught to us, but we are not keeping that into our long-term memory. In so many situations in life, we had to overcome a tough obstacle. We needed to find on ourselves the solution, and after having minutes, hours, days, weeks of troubles to find the solution, we finally figure out on our own the solution. This is something that's gonna stay for a very long time on our long-term memory, because the human animal that we are needs to keep that in mind to be able to survive in nature. That's what we are doing by trying to create the spontaneous engram. So we are letting the patient trying to discover that on his own at home. We are seeing him 2 weeks later, 4 weeks later, 6 weeks later. What is very important is to make the patient potentially having the chance to discover that on his own, and to use the FroggyMouth in your daily protocol without changing anything to what was scheduled. If you were scheduling to see the patient again 2 weeks later, do it 2 weeks later. If you schedule to do that 2 months later, do it 2 months later. We were seeing on the previous studies that after 5 weeks of treatment, many patients are having no spontaneous discovery. But 10 weeks later, most of the patients were spontaneously discovering secondary swallowing and even automating it. So, give a little bit of time to the patients to do that. And if you are not sure, if you are thinking that maybe there is a problem, because in the study we were also seeing that there is 20% of patients that do not know how to discover secondary swallowing. You have a first exercise recommended by Dr. Phyllis to be able to help them to engrab. It is called the tongue wrestling. We're going to take a mirror or a pen and just press on the muscle that we expect our patients to raise. The styloglossus, the posterior part of the tongue. Exactly like that. And we say to our patients, we're going to make a fight. My goal is going to be to lower your tongue. Your goal is to crush my mirror, crush my pen on the palate with the strength of your tongue. Is your tongue strong enough? And you will see that at the beginning you will see absolutely nothing. But after a few seconds of fighting, because of the fact that you are pressing exactly on the muscle that he needs to stimulate, you are going to feel for the first time exactly that, the contraction of the styloglossus. Then you can explain that to the parents. Also, show them how to help their child at home by having an extra-oral stimulation right here to make sure that we have a high tongue posture. And let the patient go back. Why? Because you were giving all the instructions for this patient to be able to spontaneously discover secondary swallowing. You were showing them the right tongue movement you expect. You were asking them to swallow with the teeth in occlusion. Then it's only about the patient to be able to find that out, and it is happening very quickly. After, we are in step 3. Almost the last one, but the most important one, how to reach automation. And from this point of time, that's the moment where you are assessing your patients. When he's not thinking to be observed. When you arrive at this moment, right here, he's already knowing that he's assessed because he's sitting in your chair, he's inside of your office. The point is to make the patient not aware of being assessed, so we can actually assess if we are having an automation or not. There are several exercises that I welcome you to look at on our video, on our YouTube channel, that is called free exercises, active exercises to add to your protocol for better use of FroggyMouth. Some of them, including this one, is focused on the breathing, because as I was saying earlier today, it is very important, almost the most important functions, to make sure that at the end patients automated the nose breathing. And we are also using the strength of the speech exercise, of the elocution. Why? Because if it's very difficult to not do what you know the practitioner is expecting from you. So if you know your practitioner is expecting you to raise your tongue, you will raise your tongue. To swallow in secondary swallowing, to breathe through the nose, you will do it because you know this person in front of you expects you to do so. When you are speaking, you are not thinking a single second about your tongue posture or your lip posture. But this is actually giving a lot of hints about your actual tongue posture. That's why we are using a speech exercise as a diagnose exercise to diagnose automation, but also as a therapeutic exercise. Because what we really want to teach to the tongue of the patient at this point is that its territory is inside the teeth, not going between the dental arches. So we're asking the patient to swallow or to speak and sing if there is lingual interposition or not. Then we are asking the patient to speak but with teeth closed, teeth in occlusion, to make sure that the patient is able to speak with the tongue staying inside the dental arches. Last but not least, the last part of this exercise is to really show the tongue, it should not go out. By this time, closing and opening the teeth between every number when you are asking a patient to count to 20, for example. Once again, to teach the patient and its tongue needs to stay inside at its place. After doing all of that, after being able to assess automation, we can be at the last step of the treatment, how to end it, how to decrease the numbers of days per week that you are wearing the FroggyMouth until fully removing it, and until then being able to let your patient go back outside, go back with all his friends, removing the FroggyMouth and having all the tools to be able to face life with this time a functional balance. So just as a reminder, there is 3 indications for FroggyMouth and only 3 of them: the wrong tongue posture, the atypical swallowing, and the mouth breathing. If your patient has one of those dysfunctions, he needs a myofunctional therapy alone, or if it's possible, with the help of the therapist, because there is no better results than active plus passive therapy together. So it should be our final word today. Very important to say, all myofunctional deformation, all myofunctional unbalance needs to be treated. FroggyMouth is a passive way that has as only target the automation, and it can be, if it's possible, used together with active therapy. It is not at all something that are opposing to each other. That's why we created a lot of tools that you or your therapist can add to your FroggyMouth protocol with active exercise. If you are wanting to get more information about the FroggyMouth, you are having access to all the replays of the Froggy Days, which was a wonderful online congress, 16 hours of lectures about FroggyMouth, of practitioners that were willing to share their knowledge and their experience about the device. Almost all the lectures are still available online today, so if you are needing customized protocol, advices, feedback, I highly recommend you to take a look at that. Thank you very much for your time, and if you have any question, just type the question in the commentaries of the YouTube video and we'll make sure to answer all of them. Thank you very much and see you on FroggyMouth.